Yeah.
Okay, good.
Maybe Jabron can turn it off, or I'm sitting right outside. You can call me.
Okay.
And I'll turn it off before the role play.
That's good.
Yeah.
Thank you.
Thank you.
I'd like to chat before you go.
What was she taking? I feel like that's the drugs.
While Dr. Edelstein is pulling up the slide set, I'm just going to this is probably the last behavioral RT training Andrew is doing. And
Seriously?
yeah, he did really put this whole program together. So therefore we're recording him now so we can, for many generations to come, we can show this behavioral RT verbal de-escalation.
Is he leaving MSK?
Guess what? Yes.
Oh, all right. We wish you the best of luck.
Thank you. I'm not going too far. I'll be in shouting distance. So.
So you can catch those patients.
Yeah, they cross the other side.
The
That's
ones
true.
that leave the cycle.
No, he was great. He was one of the task force members who was instrumental in developing this, and even right from the algorithm to the implementation and the training, writing the script, and it's really, I think, one of the key members in the success of this program. And it'll be sad to see you go.
You and Rena, of course, yeah.
Oh, and yes, and
I've enjoyed watching Jabron develop his public speaking skills. Each time it's better and better. Yeah, so I'm Andrew Edelstein. I'm one of the psychiatrists here. I've worked with a bunch of all the psychiatry fellows are leaving right as soon as they start talking. It's not a good sign.
I just turned her away.
Cleaning.
So basically, just to give you a little background, when we were putting this program together, the idea is there were already a couple of programs out there for education, including some people from Bellevue. A lot of these programs, these crisis management programs, actually started in the community to address issues of mentally or severely mentally ill patients out in the community where they were getting shot by police officers. And it was deemed after the fact that a lot of the deaths were unnecessary, that if the officers had some sense of what was going on, mentally, at least some cursory understanding, they would be able to engage the patients with verbal de-escalation and other tools. So it's been a very successful programs in places like Minnesota, places like California, where the idea is you give a set of tools of people that can really literally save lives. There were also some other programs that were set for hospitals and schools with children with special needs. None of these programs really fit our population, as Jabron sort of outlined, our demographic, which is primarily severely medically ill. So patients that you would need to have some understanding of what was going on as a medical crisis. So we took together a lot of these different, what we saw as like the most useful from these different programs. Many of them like 2 days long, and we are now down to, I guess, about 30 minutes. So it'll be a little bit of a speed. I think the important thing, I'll hammer the stuff that I really want you to take away. I'll try to repeat at least 4 or 5 times because I know it can get pretty, even with the coffee and the breakfast, it can get pretty dense. So here's the outline of what we're going to be talking about. The first is situational awareness, the idea of what you're doing even before you get onto the floor, what's going through your head, what way you prepare yourself, what you do when you get into the room before you even start talking or assessing the patient, then what you're actually assessing with the patient. So they're starting broadly, but then narrowing it down to the patient themselves. I think Sloan Kettering really thrives and is at its best when there are clear set of guidelines and rules in place. The challenge is that these situations are, almost by definition, are out of control and out of what we are used to and out of the norm. So a lot of what we're doing is we're giving a structure to the team. So the situation isn't just what's going on with the patient, it's also what's going on with the floor and what's going on with people around you. And that's why it's so great to have everyone here together, psychiatry, security, ICU, intensive care, so that it starts that process because you're all in this situation together. Then the behavioral intervention itself, I'll go into some of the theoretical underpinnings I want you to take away that and sort of brings up what I was mentioning before, that a lot of times there's smoke before the fire. Things will be building up and escalating, and then they'll be dying down, and then they can escalate again, and it comes back and flows across the spectrum. And finally, I want to give you some concrete skills that you can practice, probably much starting at home. I think we talk about this every time. Sometimes it's for 2-year-olds and 5-year-olds, sometimes it's for our spouses. This is stuff that can
You can take these skills with you and apply them, even regular RRTs. I mean, we have sometimes families that need to be de-escalated because their loved one is dying. You know, apply these skills.
Sure.
Or you know, spouse.
Have people had these type of programs before, like in places that do people work? Yeah, we've had programs like this. No. Where are you guys coming from before Sloan? Monty?
Monty and Jacoby.
And Jacoby.
Jacoby? Okay. Sinai? They don't have a...
Not the location I was at. I mean, they had RRTs.
Yeah. I remember in the security, do you guys get
We respond, I mean, we get calls.
verbal de-escalation training beyond this?
No.
Yeah, I mean, I learned a version of this in medical school. I started using it on my wife pretty much that night. And it's gotten to the point where she's like, "You're doing that med school thing." And I'm like, "Yeah." She's like, "I don't care. Just keep doing it. It's fine." It's like as long as you're looking, it works. It's not. It's like some magical trick. So we'll start off with situational awareness. And like I said, the idea is you want to be more organized than the patient in a situation. That's your role, is that you're creating an organizational framework for a chaotic situation. So as much prep as you can do. I talk to this about the fellows a lot of the time, like just starting in the elevator, you can already get a sense just knowing which floor you're on. Like just, you can almost get a preview. I think the average dose of Decadron and M14 has to be like, I don't know, 10, 20 milligrams at any given time. It's just a steroid rampant. I mean, there's multiple myeloma, you've got transplant with GVHD, post-transplant GVHD. You go to M4, you're thinking, are there orthopedic, or pathologic fractures, or orthopedic, what all those acronyms are, those 4-letter acronyms, I don't know. So the process begins when you're on the elevator. And then, just like I was saying, you're looking at the environment, you're looking at the staff. A lot of times, and I feel like the challenge with this program has always been that we're arriving to the scene maybe 10 hours after it's been boiling. This has been a steadily boiling pot that has now just erupted. And while things seem very straightforward and simple to us, like there's very clear orders recommended, 40% of these patients were seen by psychiatry, there's often a recommended as-needed medication. What we don't appreciate is just how things have been building, the tension's been building. Family members may be causing a lot of tension or experiencing a lot of tension. And so to be as open-minded as possible, given the situation, and the patient themselves. So again, reinforcing the side, the idea that you should be more organized than the patient. And then the other mantra, I'll try to repeat a couple times, is that the first set of vital signs you take is your own. Like you gotta know your own pulse before you walk in, because you're not gonna be able to calm the situation down if you're having your own, mild panic attack as it's going on. Or if, know yourself too, like is this the type of person that gets you, acting outside of your norm, where you might be more subdued than normal, or more easily angered or irritated. We're obligated to take care of a lot of very unpleasant people. Unfortunately, a lot of times these are, like as Ron was saying, these are people who are not, they would be they are utterly humiliated once they find out what they've said or done while they were in this state. We're privy to that outpatient. So just to keep that in mind. So the first thing you're going to do, and I like to have basically see there's 2 sets of questions, and we're going to model this later when we have patient actors, and not just acting out the scene with the patient, but with the nurse too. And I want you to really focus in on what are the quick questions you're going to ask the nurse, the team on the floor, to get a good synopsis of sort of the relevant information that you need to get started right off the bat. And I just think of what are the things between me and providing treatment. We have 3 basic treatments. We have our words to de-escalate, we have our medications to help calm and organize the patient, and then we have our restraints. So all 3 of those treatments, what are going to be the things that are getting between you and applying them. So questions about the patient themselves. Normally I would kind of throw it out there. If you guys are starting to fall asleep, I'll start calling on you, but For now, just for time, I'm going to go through them. The patient themselves, Javon already led off with this, but first question you gotta know is, can they talk to you? Like, that's your number one treatment that you're gonna be applying throughout the situation. There's the language barrier, but there's also the physical barrier. If you're going up to M17, you know that there's gonna be issues with the airway. Are they someone who needs a cuff, or they have someone who needs a valve to speak to their trach? If they're going to M4, I think at this point, I don't know how many aphasic patients we have on M4, but there's a good number of them. And it's profoundly frustrating. Just having that language barrier itself could be a source of agitation. Any recent history of violence, particularly to who, to a particular person. Stereotypically, someone who's delirious will be able to orient to familiar faces, although that's not always the case. We talked about there's some syndromes where you actually are more set off or upset by familiar faces. It might be staff that they're paranoid towards, it might be themselves. It's not so much a question of a diagnostic criteria, but it's just predictive. Like, if the best predictor of the future is the past. If the patient has consistently harmed their family, there's a good chance they'll do it again. If they consistently harm staff, they'll do that again. If it's erratic and all over the place, that's going to continue to be the case. And again, the idea of the barrier treatment in this case would be like if you have to physically lay hands on the patient, will there be any disruption of that? Any thoughts on medical history that you'd want to know? Just, I ask this because a lot of times someone mentioned something I didn't think of, and I think that's great.
Bony mats.
Hmm?
Bony mats.
Yep. Osteoblastic or osteoclastic, like they could be lytic, they could be, so you want to know where, not only if they have them, but where, if you need to apply restraints.
Airway concerns.
Mm-hmm.
Cardiac issues.
So cardiac, that's a good one. I don't know if I would put this in the first line, but I think it's a good, so ideally know the location. Again, the idea of barrier, if you need to hold them. Thrombocytopenia, if they're on any anticoagulation, are they bleed risk? I think airway is a good point. Another thing is, do they have access? What type of access do they have? Do they have IV? Do they have a port? I think one difference between us and a lot of other hospitals is that we have the majority of our patients have easy access, which makes slipping in some neuroleptics much easier than other places. We're just talking about that's on video now, right? Only if they're deemed a danger to self or others. And then, so that's just the questions about the patient. Like I said, the situation goes beyond the patient. When, as a psychiatric intern, the first question we were asked as we were called to emergency is like, okay, who's drawn up the Haldol and Ativan? Like, is it ready to go? The last thing you want is people, you finally make the decision to give them medications, and then that your barrier to giving them is that someone has to now go to the Pyxis, draw them up. That person, you have to figure out who that person is going to be. As much, if you can figure that out before you even get to the scene or get to see the patient, the better. Security nearby or present. In every behavioral rapid response, at least 2 security guards will be called onto the scene. The question is, and it's important, I always feel like it's the best thing the first thing we should be doing is be shaking hands and just introducing ourselves. Everyone knows each other by name. The idea we're all on the same team, yeah. Yeah, well, that's why we're here. I mean, that's why I want to keep spreading that message. The idea is that I think the issue before behavioral rapid response is, and it's still an issue, like we'll show up, someone will be saying this is an assessment that psychiatry needs to make, and we'll say, well, maybe we should have patient services, and patient services feels like the nursing or the primary team, there's a lot of pointing to the left, but the goal of this program is to ultimately get everyone on one team, the behavioral rapid response team. And so it's good to know where everyone is. I think ideally, you want to minimize the number of people in the room, but with a clear sense of what would be the alarms that you'd want someone in there with you, security with there with you. Are there family or friends nearby? Are there staff? Because like I was saying, delirium, orienting faces, familiar faces are key, they're essential. Can't tell you how many behavioral rapid responses were alleviated by giving the phone to like 75-year-old man and his daughter basically telling him to cut it out and go to sleep. I think, Giovanni, we're keeping that statistic.
Which one?
Just the daughter telling their father to go to sleep and knock it off. I think at least 4 or 5 for me.
Yeah, sometimes the family and the
It's huge.
dynamic.
They can be helpful. And you want to know what's already being done. Like I said, this is a process that's been brewing up for a while. A lot of the times the problem is that one person thinks, oh, well, we just need to get this person a tray. Another person thinks, no, we need to get this person medicated. Another person thinks we just need to leave this person alone or let them leave the hospital like they want. And so there's a lot of things going on at once. It's helpful if this patient's been NPO for the entire day for an IR procedure, the procedure is canceled, at 4 o'clock, they're starving, they're aggressive. Sometimes the simplest solution is just, okay, who's getting the tray, who's ordering the food, and knowing what's already in place. And so that's just the situation, the assessment, the first line. And then we're looking at the next layer. It's always good to know the baseline mental status. Living independently, we've had patients, I know we've consulted in ICU, trying to wean them off sedation, who have a history of autism spectrum disorder, but severe, never had any language, always at functioning level, maybe like a 3 or 4-year-old, never having language. It's good to know if we're trying to get them back to the baseline, we need to know what that baseline is. Psychiatric history, like I said, the past is best predictor of the future. I don't think we need to know that right off the bat necessarily, but that's something that we slowly collect over the course of the BRT, assigning people to figure that out. And certainly substance use, daily alcohol, benzodiazepines in case there's concern for withdrawal. I think one of the top 2 things that seem to be the major culprit for mental status changes are, they're rotating the PCA or just starting PCA, and there's, they're going from Dilaudid to fentanyl, and there's this dramatic shift. So opioids, and then the other of the 2 would be steroids, addition, titration. So those are the things that slowly, gradually get over time, but I don't think you necessarily need to do that right off the bat when you're just riding to the scene. And so I'll repeat it again. The idea is you want to organize yourself before the patient. You want to take your own, the first set of vital signs, you take your own. And then the addition to that is you can't treat patient if you're a patient yourself. That this is an issue that we've run into, and as we were putting this together, I remember Deb Stein talking about her experience as a nurse. When she was by herself overnight and the patient was about to remove the line that they've worked forever to get, just the instinct just to move, to reach over to cover it. And that right there, I think that was the first time she said she was hit. Her structures barely missed getting punched by a patient. I think a lot of our instincts are to preserve our patient. And what we're really trying to reinforce here is that's not your job. If they're running for the door, your job isn't to be a barrier. Your job is to be the person who gets security or NYPD if needed. That's what we were really emphasizing. We don't have like that's our takeaway.
Our job is not to make the patient more agitated. It's just sort of de-escalate and figure out how to take care of them when you get them into that state where they're just calm and you can have a verbal dialogue with them. But if they're going to pull out their Foley, I mean, obviously we don't want them to hurt themselves, and you want to give medications and to control that behavior. But the point here we're trying to make is make sure you don't get hurt. Your safety is also very important. Don't get hurt in the process. So if you're going to actually physically put hands on a patient for whatever reason to actually apply a manual hold so you can give medications, Andrew's going to go over how to do it in a more structured way where you're all on the same page. You're communicating your thought process to the rest of the team. Like, this is how we want to approach it. Think about the situational awareness, think about the safety, and just have a plan.
Yeah, I think there's a time here when a patient gets their clozapine, which is the medication used for very treatment refractory schizophrenia, on M5. They had chest tubes, their tubes were in. I was walking into the room and they said, you walk another step further, I'm going to pull this right out. It was like a hostage situation. And I had to remind myself, we can certainly, the surgical team here is good, the ICU team here is great, so we can always intervene there, but we can't intervene if I'm in the urgent care with laryngeal edema after being strangled. So with that being said, it actually ended up working out, and we'll get into a little bit more later. It gave him a sense of leverage that he needed in this situation when he was feeling paranoid. And by reminding myself to stay back, it was actually helpful for him to feel like he had some power in the situation. For the most part, we don't really have that many like antisocial, sociopathic patients. For the most part, they are disinhibited. They're not looking to manipulate directly. It's more just act of desperation. So organize yourself again before the patient, who's the team leader. Psychiatry as they arrive will take over, but I've been in situations where we show up and we don't, unless we're wearing our psychiatry headbands, it doesn't. So for psychiatry people here, just make sure, I think the best thing we could do is just go around, shake hands, be an alert for us. It's not like the RRT, medical RRTs, where you're just trying to fit as many people in the room as possible. So a lot of times it'll be a big crowd to wade through.
It's okay to say it out loud once you walk into the behavioral RT. Psychiatry, I'm in charge.
Yeah.
It's okay to say that.
Yeah. It's the only room you can walk into and shout, "I'm a psychiatrist," and we'll be relieved.
Any thoughts in the back? No?
We love hearing that.
I got
I don't leave. We get very relieved when we hear psychs in the room.
Finally, they arrived, yes.
Yes.
I've been on a lot of these behavioral situations where the patient causes out of behavior, extreme bad behavior, and the medications are not working. And I hear the nurses and doctors talking. I mean, is it the right combination, or you just keep doping the patient up until it finally kicks in?
So I think we've gotten better. I mean, part of, and it's hard to use this data that Siobhan showed because we have nurse practitioners on overnight who like pretty much set up shop at M4, I think. That's like Lindsay and like her first place, Katie's first place. So a lot of what we do is waiting. Like it's like that's a big part of psychiatric training, is that these medications take 30, 45 minutes. Like the anxiety medications that we give take longer to act than a panic attack, for example, takes to go on for itself. So a lot of situations I found myself in here as a fellow was showing up, leaving a patient at night, seemingly relatively calm, and then showing up the next morning, they had gotten 5 times the amount of Ativan I recommend for someone their age, just because things got added, and then they're sleeping the whole night, or the whole day rather, and then up at night. So that's, as stressful as that is, that's what we're offering as that perspective, to say like, look, we need to give this time to metabolize. We might need to restrain this person to give it time to metabolize. As uncomfortable as that is, it might be safer than giving extra medications.
Well, then I hear at times also that is it possible that has the opposite effect on the patient?
Yeah, you can get restless, you can get apathetic, absolutely. I think the takeaway here though is just, people can have their disagreements. I think it's the next step, like I keep saying, is like we need to have a good way of having a debriefing at the end so that people feel like their voices are heard. The important thing, when things fall apart in behavioral rapid response, is when there's a lot of conflicting opinions, and every opinion is valuable and we need them to make sure the patient's safe in the future, but just in the moment to make sure there's not too many cooks in the kitchen. But I think it's just in that moment, even if the psychiatrist is wrong, which we are, a lot of times we're just kind of, we have to take a guess one way or the other. But there's a moment we should all collect together to figure out what we felt could have gone better. I think is a really important aspect. So that's the thing, is everyone should feel needed, and that's going to be something I'll try to go back and reinforce too. Is like everyone likes to feel needed and valued, and that includes patients, that includes the staff on the scene, that includes the family, and so we want to make sure everyone feels engaged and part of this, and not push aside. So we want to make sure everyone, in the same way when you have like a BC, I was at BCS, right? It's been a while, ACLS. I used to check my card. So the idea is like you don't say someone get the AED, right? You say, Jabron, can you get the AED? I had a mentor who said the best way to starve a dog is to tell a room of people to feed it. Okay. So that requires a little explanation. But sometimes, okay. So, but it's like if you tell someone will say, "We'll figure someone else is going to do it." But if you're feeding my dog this weekend, I don't have a dog, but you would say that's inappropriate. But but that's the same principle. Be mindful of your own emotional response. We have to take care of patients who are going to be saying really crude, sometimes racist, sometimes sexist, sometimes just absolutely god awful, and I can tell you, and the goal is to not necessarily push those emotions aside, but just to be aware of them when they do emerge. They'll be pushing buttons. Like I said, most of our patients not intentionally, but when they are in a state, again, it's utterly humiliating and is a total departure from their baseline. We like to start low in terms of people in the room and build up, but just have a contingency plan, again, for how you want to handle the situation. If you want security, if you feel comfortable asking security to stay outside until you can assess the situation, you feel comfortable with it, you know the patient, or if you feel, but you want to know, like if they're shouting, can you please come in? If the patient comes, you see the patient coming towards the door, can you please keep them from getting into the hallway? If they're already in the hallway, coming up with a strategy to get them back or redirect them, not necessarily to their room, but maybe to a treatment room. It's good to have that plan laid out before you're actually even talking to the patient. We're eventually going to start talking to the patient. We're getting there. This idea of any object can be thrown. Like when you're walking into the room, I did my medical school training down in Kings County Hospital. We got a couple New York people, right? We had Monty back there. So they figured that there's a big problem with patients throwing chairs, so they figured the best way to stop patients from throwing chairs is to make them really, really heavy. So then they had a problem with patients throwing really, really heavy chairs. Eventually they bolted them down. But the same idea, you're walking into a room, just immediately, and we'll try to practice this here with the patient actors. What are the things that could be thrown? What are the things that could be ripped out? Where are the lines going in and out? Is the patient dressed? Clothes available? Do they have a lot of these patients, if there's awareness, they've got their belongings locked up, but not necessarily. Do they have their shoes on? We've had patients that just seem to spontaneously ask for their wallet for no good reason, and they kind of confabulate or figure out a reason for why they would need it, but that's a sign that they're about to dash out the door. When you see family members in the room, they can be helpful. They can also be causing agitation. It's good just to take stock. We make a point, we're just treating patients, we don't treat family members. Just a general rule of thumb, again, returning to this idea, everyone wants to feel valuable, needed. More likely than not, if the patient is in this situation, a lot of times family member sees you as an adversary. They see you either as contributing or not helping while they're in their distress. And the best thing you could do is just to recruit them to your side. Like, we are the experts in emergencies, but you are the expert in your loved one. What can you tell us what we need to know? Or could you get this phone number for us? Make them feel included and part of the team if you feel like they're not helping with the patient themselves. So we're going to talk to the patient. What are some of the things you guys look for when you see, right off the bat, that's a warning sign?
Psychomotor agitation, clenched fists, changes of behavior.
Yeah. Yeah, you see clenching, moving. Typically, someone who has their wherewithal, if they're maybe like a more antisocial patient, like they'll start to square up if they're about to punch. So that's a training in like a typical medical hospital setting. It's like, watch out when you see a person squaring up. Our patients, it's more you're leaning over and all of a sudden to take vitals or to remove a cuff and they're reaching out. It's not a deliberate act, it's just or you're reaching out, they're falling. And I mean, I don't know what happens when a patient falls, but it must be absolutely awful from an administrative standpoint, because everyone will do everything they can to keep the patient from falling, even throwing themselves and putting themselves in danger. I mean, I understand it's also bad for the patient too.
It's also,
And
for the record.
For the record,
just 10 minutes.
Okay. Like clenched, relaxed? Where's their attention? Is it wandering around the room? Is it focused on you intensely? Do they have access to the door? Like I said, both you and the patient should have an escape route. Like you shouldn't be a barrier. You can't help the patient if you're a patient yourself. So if you can make this look natural and cool, which I can't make any posture look natural and cool, so I'll just do it. This is like the posture that teach you as as a police officer. You're not like creating a barrier between the patient and getting through the door. You're leaving it open, and if you need to leave, you can just turn quickly like that. Most importantly, you should just feel comfortable. So if you're not comfortable doing that, then you don't have to. But that's just one way to think about your positioning in the room so that you can enter and leave. Like to position yourself in front of the door. If you need to leave, if they need to leave, if they see that exit, they can walk by. And if you need to leave, this is a very simple concept that required very complex animation. That's the idea. So just that's part of the situational awareness. There's a little bit of like a party icebreaker I like to do.
I mean, we have not allowed, we have 10 minutes left, but
Okay.
we should do it, yeah.
All right, so if everyone can get up, it's part of the interactive part of the show. See if we can move some of these chairs.